Good morning. My name is Mike Heenan. I'm the president and CEO of the St. Joseph's Health System. And it's a real pleasure to be with you today on this important topic. When Matt asked me to come and give an address, he asked me what topic would I like to talk about. And I thought about talking about mental health and addictions because St. Joe's is the second largest mental health and addictions provider in Ontario. I thought about talking about my time in government and how it's influencing my leadership within the acute care integrated healthcare system. But then I thought, well, what is the one topic that hits my inbox every single day, and how does it influence the direction we're taking at St. Joe's? And I'll get into some economic issues a little later, but if you look at an Ontario hospital's balance sheet, 70% of our costs are labor. And so what I'm going to talk to you a little bit about today is that 70% and how it influences my inbox every day. You'll notice from the title of the slide that I'm calling it an epidemic, but I also want to recognize that before we begin, a couple of key points to raise with you. First, the vast majority of patients and families throughout Ontario and Canada are respectful, grateful, and supportive of the quality of care we provide. They're enthusiastic about our publicly funded system. They're enthusiastic about our nurses and our doctors. And they really do appreciate the care that they receive. One of my sidebar comments will be, it was very difficult going through federal and provincial elections lately, where people doubt the integrity of our healthcare system, which has a moral impact, in my opinion, on our great nurses, doctors, allied health professionals. That in mind, I also want to let you know I'm going to be very candid today. The stories and incidents I'm going to share with you contain language that may offend some of you, but I think it's important that we have this candid conversation about this important topic today. I was recently asked, why did I become the president of St. Joseph's Healthcare Hamilton and St. Joseph's Healthcare System? And it's because I fundamentally believe in three things: taking care of patients and families, integrated care along the continuum, and the mission of the sisters, who were one of the first set of leaders in this province 170 years ago to come and take care of patients on the shores of Lake Ontario. And it was the sisters who within St. Joseph taught us the mission of selflessness, purpose, and nobility. In fact, there was a slogan at St. Joseph's Healthcare Hamilton one time called, "It was an honor to serve the sick." But the other side of that reference is when we frame healthcare as a calling above all else, we can unintentionally normalize danger. We can silence harm, we can expect sacrifice without protection, and we can create burnout. Now, it's interesting, I'm coming to you during June. All across this country, in the month of June, there are thousands of students who will cross the stage on one side, have a diploma as they walk across that stage, and on the other side of that stage, they will be called doctor, nurse, or allied health. We are holding them up to a big standard. We're thankful they're calling themselves to this profession. So it's a time of hope for many, many families, knowing that their daughter or son is a doctor or a nurse. But what we don't tell them when they cross that stage is that they are 5 more times likely to experience violence at work than any other profession. Between 8 and 38% of them will suffer physical violence at some point in their careers. 61% of nurses, and this is Canadian data, the third point, 61% of nurses, 74% of paramedics, and 89% of personal support workers are subject to abuse and 50% of all violence is inside an emergency room. If you are Black, Indigenous, or a person of color, you are subject to greater incidents of violence and racism. And literature most recently is indicating that that leads to burnout, which decreases patient safety. But beyond the literature and the statistics, how do I know this as the president and CEO of a health system? This is my inbox every single morning. So this is formatted by day, but in essence, I will receive anywhere from 5 to 7 events every day in my inbox. When I became president and CEO, there was an article in the New York Times that talked about this topic really increasing in the United States. And so I asked for every single staff incident to come into my inbox. So I'm going to show you what my inbox actually says, not just what it looks like. Purposely not going to cover mental health today because it's not always in mental health that these incidents occur where their underlying illness is impacting them. But I will talk about it. So here's incident number 1. You'll notice I've covered it up for protection of people's identities. This comes from our emergency room. The description of the incident is the writer was trying to change the patient's brief and clean bed sheets when the patient became increasingly agitated. The writer or the staff person was kicked in the abdomen, grabbed on the wrists, and punched in the arms. This is an incident related to sexual behavior in hemodialysis. Was helping patient in bed, patient was sitting, and then lightly grabbed my breasts. The third incident is in home care. And I want to acknowledge the leadership of my Vice President of Post-Acute Care and Executive Director of Home Care, Nadia Serrani, who is a woman of color, because this would not have been reported without her leadership of talking to a PSW who is a minority. On the right-hand side, you can't see it as clearly, but on the right-hand side, it says he pushed my hands towards his penis and said, "Go deeper," inside someone's home where she was alone, because it's a home care incident. The next incident has to do with racism on a medicine floor. I won't describe it in detail other than maybe the last line that says the bathroom, because he was able to provide himself a shower a few days ago. But during this interaction, the patient stated these and then uses the P word to describe a woman of Hindu or Sikh background. The next incident is also racism, and it occurs in our complex care unit. And you'll see from the second last paragraph, or at the bottom of the second paragraph, it is a woman of color who is Black, and the patient yells, "Go live in the jungle where you belong." This is the true case of what happens in our acute care institutions across this country. I haven't covered a doctor, so let's talk about a doctor, because this happened 2 weeks ago. 2 weeks ago, a doctor got a threatening phone call, and this is the transcript. It's been amended to tone down the language. But in essence, it says, line 9, in Buffalo, I saw on the news a couple of months back a guy who came to the hospital and shot a doctor. That's bloody great, but you can't do that here. I don't have access to a gun. Line 12, if I had a gun and I was a single man, I would have shot you long ago. He later goes on in the transcript to threaten that he knows where he lives because the doctor's address is publicly available on Canada 411. He leaves clinic early to go home to take care of his family, his mind racing as he drives home. He notices as he drives home, I've missed my exit off the highway. He gets to the next exit and says, that's how I know I missed it. His mind is racing. I got to get to my family. He gets to the third exit, forgets to hit up the brake, and has a single car crash into the ditch at an exit. This is his 3-week-old Toyota 4Runner that saved him from harm. But I also have staff who talk to me, not just report, but to talk to me.
Instead of coming in the morning wondering if you will be subjected to this abuse, it's more so how many times will I be subjected to the abuse. My journey started originally as a registered practical nurse. So I came to St. Joe's into the renal program, so on nephrology. Generally, when people go into the healthcare system as a career, they go into it with some deeply rooted motivation to help and serve others in some capacity. To know that you're going into an environment that is already challenging when you take all of the violence out of it. So there's medical complexity, there's a lot of clinical skills that the staff need. When you add in the workplace violence, it's sad that that is an added layer. Back when I first started nursing, there was a high regard for healthcare staff, nursing staff. You know, patients and visitors, they asked questions, they asked for permission, where can they be, how can they help. It was a mutual respect between us. So we gave the open communication and transparency to the families and the patients, and they gave that back to us. During COVID, there was all of those celebrations that nurses are the heroes of the healthcare system, but it didn't feel that way working as a nurse in that environment. Having behavioral patients, the name calling, the abuse that staff took was much more prevalent. I was actually quite shocked when I returned at how common it has become and how tolerant staff have become, that it's just what happens. It's no longer a shock, it's just what's expected in your shift. So it's, instead of coming in the morning wondering if you will be subjected to this abuse, it's more so how many times will I be subjected to the abuse. I did get called down one morning. I wasn't actually supposed to be on site, it was before I was supposed to start, but I was there, so I went down. The patient was quite upset. He was swearing, he was threatening staff, he was threatening staff's families. He had commented that he knows where people park, he knows where people live, he knows where they grocery shop.
How does that feel?
It makes you feel nervous. It feels like you're always looking over your shoulder. So you try to change up potentially where you park. You try to change up, I'm a very routine person, so trying to change up where you walk, what pathway you take.
How often does the subject of violence come up?
Daily. So as a manager of an inpatient unit, so where patients are staying, every morning I would wake up at home and look at my phone before I came into work, and just sift through the emails of reports of what happened overnight.
What is the toll? Like, what toll is that taking on yourself and your colleagues on those daily conversations?
It's causing nurses to leave frontline. People go into leadership to inspire change, to look at innovative ways to provide patient care. But there's no time for that because you're dealing with all of the daily fires of the abuse that occurs on the units. I want people to know it actually exists, that it truly is happening on a regular basis. No one here wants people to wait, but I want them to know that they're human.
For those in the room, we are joined by Christina Bowman today. So I ask you to give a round of applause for her courage to tell her story today. Christina, if you can acknowledge yourself. So we've tried before. We've looked at this topic many times. So how are we still here? How did we get here? So the issue is not new. In 2015, under the leadership of Rob Devitt out of Toronto East General at the time, and Anthony Hale in partnership with the ONA, they looked at the topic. In 2019, there was a parliamentary committee from the House of Commons that looked at violence amongst healthcare workers in Canada. ONA, emerging out of the pandemic, noticed that their members were not being recognized as heroes any longer, or were now subject to this. And the Canadian Association of Emergency Physicians in 2022 also put a call out to their members to be aware. So why are we still here? It's because violence and incivility are part of a broader societal problem. These are literally pictures I took myself as I walked into different institutions. So I bank with TD, and you'll say that they are also worried about respect of their staff. I went to get a passport renewed, and they told me I would have to leave if I didn't behave at that particular moment in time. I walked into a Starbucks this morning, and this sign was up at the brand new Starbucks just below this building. And so Starbucks is seeing this as well. There's really, and I'll give Anthony Dale a little bit of credit here for introducing this concept to me. It's new because it comes from Dr. Roberts, who spoke at the OHA convention. What's happening in our society is a mistrust of information. There's a mistrust of institutions, and there's the concept of individualism or hubris, and it's impacting our society everywhere. But unlike these companies, we cannot refuse service because someone's coming for emergency care. So what does that look like? Well, patient acuity in the hospitals is increasingly complex. Over the last 15 years, I've been in the sector about 20, 22 years. We've talked about, just put all the high acuity inside the hospital. All the low acuity should be elsewhere. Probably right. But that manifests that sickness into an environment that gets violent. So due to illness or unknown symptom, people are scared, they're nervous, they're frustrated, and therefore they may not be their true self. And so we also recognize people come to us at a point of vulnerability. There are not many doctors in the world that can attest to a patient interaction that says, I feel great today, doctor, tell me why. People are coming with illness and they're scared, and we need to recognize that. But it also manifests itself because of multiple comorbidities into violence for our staff or frustration of patients' families. But there are structural issues that we must also keep in mind too. There are system frustrations and pressures with the healthcare system overall, the high costs of it when we have to pay out of pocket for so many things, the limited treatments that might be available, or the wait times that can trigger regression as you wait inside an emergency room or a family doctor's office. We had understaffing throughout the pandemic, and so workers were less able to assess patients for potential behavior problems, or they might be going into a room alone when they needed to be accompanied by someone. In my world, in the hospital part of my world, and St. Joe's Health System does have services in long-term care and home care, but on the hospital side, it's very transactional. We want you in and out in 2 days. And so we have weaker relationships with patients and families that would enable us to de-escalate the problem that perhaps long-term care or retirement homes might be able to manifest a little bit better than us. And then we have physical infrastructure challenges that do not adequately create safe spaces. One of the incidents I did not share with you today was of a new nurse, young nurse, walking a patient into a clinic room. The clinic room had a window, but the blinds were down. She entered the room first, and there was a single door. There was no exit to the door. And so she got harmed. The physical infrastructure was not built to modern standard, where there was an exit plan. Home care workers go into homes of different situations all the time. And so they actually don't even have an infrastructure to train them, because they might be in an apartment building one day, a well-off person another day with 2,500 square feet, or affordable housing the next day. Or for our mental health workers, finding a patient under a bridge. And so we need to think about the physical spaces by which we take care of our patients and our staff. But we tried before, so now what? Well, first, if the moral argument is enough, let's talk about the economics of this problem. Multiple systems, including Canada, the US, and UK, have now quantified violence as a multi-billion annual burden of healthcare. The OHA estimated 10 years ago that it was a $23.8 million cost in 2014. In 2023, the US ran a study just recently published that $2.7 billion of US dollars by US hospitals is spent responding to violence. That's about 400 million Canadian if we take that to our Canadian environment. 769 million pounds in the US, in the UK is due to violence, which is about 767 million Canadian if we take their model. And the costs quickly stack. There's unverifiable costs of overtime, security, sick time, staff turnover, and legal exposure. Not to mention, every lost provider due to violence compounds the health human resources crisis, driving up recruitment and training costs. But what can we do legally? Is there a legal answer for us? Well, I asked our lawyers that question. One, a worker in Ontario can refuse unsafe work. They can set limits on care. We can call the police and pursue charges. Many are reluctant to do so. We can restrict access, especially for families with trespass notices. We can enforce risk assessment and violence policies, and obviously we can support staff through WSIB and other insurance type claims. But we have limitations because it's healthcare on how much work we can refuse. We have limited civil recourse because we're in a publicly funded system. We have human rights constraints because, again, they're here for emergency care. And we cannot deny it, as it's noted. But what is happening around the world on this topic? In the United States, a recent article in the Journal of American Medical Association noted that there is increasing penalties for assaulting healthcare workers in 40 states. In Oregon, you can receive up to 5 years in prison for such an item. In Colorado, they passed anti-doxing laws to protect healthcare worker privacy. In Texas, there's parts starting these plans around mandating prevention programs. I didn't cover it today, but in Australia, you can get up to 14 years in prison for assaulting a healthcare worker. You will notice in the bottom, and I'm not advocating it, I'm just using it for sharing of knowledge. 29 states have passed or are considering laws allowing hospitals to establish independent police forces. This is how bad it is getting. And look at the other one around carrying firearms. I'm not advocating that for today. I share it only as this is how serious it's getting in our world, and we'd be naive not to think about where this might go. We have a member of UHN with us today, and so I'm going to acknowledge the great work of UHN that published just recently a new framework that they have developed at UHN. They have verified that it is widespread, that underreporting is rampant, that we have fragmented data systems with regards to this across our sector, whether it's long-term care, home care, or acute care. And they've implemented a system-wide prevention and management program around patient flagging, detailed care planning, mandatory staff training, and integrated oversight and governance. So what do we do at St. Joe's? Why is Mike here today? Well, at St. Joe's, it's early, but we're building. And I'm going to conclude shortly, we're not perfect either. I think we do have to approach this with some humbleness and honesty with our staff. So what we're doing is we actually are building off of the OHA Summit from 2015. It's 10-year-old work that they did, but important work. And the themes of culture, communication, education, policy, infrastructures was what that report talked about. So I'm going to cover that. We are taking a very long view. When I shared those incidents that I shared with you this morning with the board was like, fix it and fix it now. And I told them I can't. It will take 3 or 4 years to fix this problem. So the leadership of the hospital and the health system and our board is committed to taking a long view of this, because that's realistic. Post-pandemic, we're getting the basics right. We're simplifying reporting. And we had 3 or 4 different reporting systems. If a nurse reports something in one system and it's not in the right system, we actually now work with that nurse to do it for him or her so that they don't go through the trauma twice. We were focused on the minimum standard, things like security cameras, personal alarms. We looked at the tools and education and training of what staff do. And we're just about to open a new ER triage area, and it has double doors and in and out for staff because we're paying attention. In our world today, sadly, south of the border, because of the new leadership there's an attack on diversity, equity, and inclusion, but not at St. Joe's. We are doubling down on DEI because most of our incidents are related to those who come from those communities. And so we've actually expanded our data collection so that we can actually get demographic data related to racism and sexual assaults and just not physical. And I'll talk to you a little bit about a senior leadership response team. We're addressing zero tolerance by saying, well, we do tolerate it actually, don't we? We say do not tolerate, but yet because we can't refuse work, we do tolerate it. So we're humanizing the experience. We are now writing things down in families' charts because of their behaviors. We are looking at those legal options, and we're going to pivot our campaign, and I'll talk to you a little bit about the plain speak of our work in a moment. And then finally, we're not perfect, and I'll talk to you about an announcement that I'll be making tomorrow at St. Joseph's Health System. We have created a racism and sexual incident response team known as the CERT, the CEO Initiated Response Team. Every day I read every single one of those incidents, and if one is related to racism or sexual behavior, I will email the staff person directly. I will copy their local leadership, the vice presidents, occupational health and safety, the security team, and their unit managers. They will respond to that patient, or sorry, that staff person immediately and offer all supports to that staff person within 12 hours of the incident because they may be off shift. Every single day. We also are pivoting our campaign on how we talk about this. This is our current sign. You will notice it's full of words. You will see it's different colors. It's not easy to read. My sense of humor says it's like a Robert Munch book. We do this, you do this. We do this, we do this. We speak too kindly about this. And we're not plain speaking about it. So under the leadership of Carly Weeks, who's with us today, and Carrie Fletcher, who's with us today, we are launching this campaign tomorrow. Based on the Hippocratic Oath of do not harm, we are going to show the faces of the staff who have been assaulted and are subject to sexism and racism. We will be calling it do no harm. We are simplifying. We're also running a campaign called It's Not Okay. If it's not okay in a coffee shop, it's not okay in a hospital. It's time to speak bluntly, plainly, respectfully, but directly about this topic. Have we made progress over the last year? I would say so. On the top left of the slides is month-over-month comparison for April and May, and you'll see the increase in reporting on physical, verbal, sexual, and racism events. And so our staff feel more comfortable reporting. On the bottom, the blue bar is last year's total. The orange bar is this year's total to date for only 10 weeks. There were roughly 598 or something on the screen there with regards to the number of events of physical that will cross 800 this year. Racism, roughly there was 35 or 105 last year. That will go close to 200 this year because people are now feeling comfortable. The good news is on the right-hand side is we are reducing the lost time injury metric. And so people are not getting harmed at work and losing time at work because of the systems and attention that leadership is providing. But we don't have all the answers, and so we're asking for help at St. Joe's. We know we're not perfect here, but we know this is important. So tomorrow I will be announcing to my organization that we have struck a new partnership with the Institute of Healthcare Improvement out of the United States. They're an international healthcare quality and safety organization, a not-for-profit. As an academic health science center dedicated to learning, they will come in and assess all of our work independently and make a recommendation to the board of the improvements we need to make, recognizing that we will all have biases as leadership and managers of our staff. And so the IHI will be entering St. Joe's at the end of July, in August and September to make this assessment. We're also asking patients to help us. One of the incidents I did not share with you, which I will now share, is an incident that came across my desk. And it said, the nurse reported, I was changing a patient's brief, and the patient reached out and hit me. Upon further investigation of that incident, it was a 92-year-old Chinese lady who did not speak English. Her family did not live in Hamilton. They only visited twice a week. She did not understand what was happening to her when they were touching her for pericare and brief change. It was not her fault that she reached out and hit someone. You might hit someone too if they were touching in the wrong way, perceived wrong. Under the leadership of Andrea McKnight, our Director of Professional Practice, we've created the brief concept. And so now we're training every nurse in our organization and PSW on how to appropriately change briefs of a patient. And so patients are teaching us how to improve care through this work. So my final call to action, I'd be happy to answer any questions, is a couple of things. One, as leaders, please recognize you have a moral and legal responsibility to take every precaution to keep your staff safe. And again, if you don't believe the moral arguments, 70% of your budget is staff. The Ministry of Health and Ministry of Labor need to restrike a focus that addresses this issue in our sector and take a leadership role that can standardize rules and regulations across our sector. It can't only be the Ministry of Health, the Ministry of Long-Term Care needs to do this. Because we have so many silos in government. Who takes care of primary care? Who takes care of these things? And so we need a province-wide government-led initiative here, like the federal government is taking. We need modern capital infrastructure improvements in all of our buildings. I have a 70-year-old building taking care of medicine. I have multiple patients in rooms. I don't have single rooms. And so that also leads to risk. We need to talk plainly about this. And we need to use the human rights and criminal codes where appropriate. Little known, however, was there was a private member's bill struck by a Conservative opposition MP in Ottawa right before the last federal election, and it received unanimous consent. And so we need to applaud our federal leaders who put their partisanship aside and decided to pass Bill C-321. It was sitting in the Senate when the Prime Minister prorogued Parliament to have their leadership campaign and run an election in which Prime Minister Carney won. I'm asking all of you today to please reach out to your federal party members, no matter what aisle they are on, and ask them to reintroduce that bill, which brings new criminal code stipulations related to healthcare workers. We often think about partisanship in certain ways, but we should applaud Parliament Hill for what they did under 321. And we should be encouraging them to reintroduce it under this new mandate. With that in mind, I appreciate your time today, and I'm happy to answer any questions. Thank you for your time.
So if you have any questions for Mike, feel free. Mike, if there's questions in the audience, can you repeat them for the people online?
What we've learned is that because of the governance of students, they're not employees of St. Joseph's Healthcare Hamilton. They are reporting to Mohawk or McMaster. And so we, and then they have 3 or 4 different reporting structures. I have to give one to Mohawk, I have to give one to St. Joe's. Like, there's different ways to deal with that. So while we're lifting the culture, we are going to be looking at, and we have our manager of medical affairs sits on our governance committee for this exact reason. I will say that some of the students have said, I want to graduate. And so therefore I'm afraid to report because I don't want to be seen as an adjunct. And so we have to do something from there. The second question is, how are we engaging the union? So our joint occupational health and safety committee remains intact, and we've been working through the union, through that committee, through the unions. They were directly involved in particular on raising the concept of you actually do tolerate. Don't say you don't tolerate, because we do. So when you walk into any hospital and it says we do not tolerate, what does that mean? For the bank, it's like leave and take your money. For Starbucks, it's like don't come back here again. So we do sort of tolerate some of this. And so the union's been very good at sort of saying it's okay to say we're here. And so our labor partners are important partners. I'll pause there to see if there's any questions in the room, and then I'll go back to see Philip D.
I'll just quickly though, just with your engagement in the union, how have you engaged the community in the policing and security and that sort of thing?
Yeah, great question. We did have a shooting threat at St. Joseph's Healthcare Hamilton, in which the Hamilton police received the call. Because we're a regional mental health center tied to an emergency psych, the Hamilton police are very big partners, very important partners. We are going to have them run a session in the fall on how do they de-escalate. Now, here's the difference. They have a weapon on them. So, but they are going to teach us how does their officer de-escalate without touching that weapon. Yes, we have CAMH does wonderful training in this area around de-escalation. And there's a healthcare way to do it. But just for learning, the Hamilton police do that. We have spoken just off the record with some media outlets around, we would like you to start covering some of this, and they are interested in that topic. We have a patient and family advisor on this work, and she is supporting this work. And so I think we'll see the community more engaged as we launch our campaign of coming days.
Do we have any questions? Yep, we got one here.
So curious, it sounds like you're doing more data collection to understand the problem, which is great. I'm curious in your discussions or your data investigation, has the concept of repeat offenders or someone who's violent once, or how many are multiple instances from the same individual? Is there data that proves that out or not? Or just curious at that,
Yeah.
what your discussions around that topic have looked like around preventing the next one?
Yeah, so we flag offenders, so if they're coming in, we know they may have had a previous event. There are some, Australia, will deny dialysis for a day. Right, it's not life-saving therapy, you can wait a day. We can give you a cocktail to get you through the day. So there are options that are available to us, but we're early in the journey on that. So we need to think about what is required care on those type of things. Welcome, Carrie Fletcher.
Thank you. So we are actually, Tides is near and dear to my heart. I was very involved in actually creating that training at CAMH, now at St. Joe's, and we have CPI training currently at St. Joe's, which is rolled out across the organization. But we are actually in very early talks with taking a shift to the Tides training. But all of our clinical staff, and we are coming to our clinical support services staff as well to get that training across the organization.
Thank you for the cameo.
Sorry.
Appearance.
Can I ask you any question?
Yeah.
How do you find your compliance with training?
So it has increased drastically. We've also been working with the Ministry of Labor because we have had incidents on some of our medicine units. So we have much more of a laser focus on our compliance, and it has gone up quite high. I believe that we are close to 90%. It's always challenging working in a 24/7, trying to get people in, people on leaves, etc. But it's much better.
This is a stated goal. It's a clear goal of the organization. So every manager knows that training is a requirement and is driving that locally on their units. And safety huddles, etc. I'm going to just go, I think, Matt, if I can scroll here properly, if I get this right. So Denise asked, what are your thoughts on changing the narrative that violence is part of the job? Nurses and healthcare workers, when do they report, are still being asked, what did you do to cause this? Appreciate your call to action. What advice do you have in that realm? I think that's what the question is. I don't think we can't take a fault. So if you're living in an organization, for the person who asked the question that says you're going to a nurse's, what did you do to cause this? I'm sorry you live in that environment. This is not about fault. As I say, patients, even in long-term care homes now, are more and more complex with dementia, with failing health. And so I'm not trying to blame a patient. I'm not trying to blame a nurse. But the reality is that somebody gets in their car at 6 a.m. in Flamborough, Ontario, and drives 30 minutes to get to St. Joe's to start their shift at 7. By the time they park, pick up a cup of coffee, and go to shift change. They work 12 hours. They then go home. It's 8 o'clock at night, and they have 2 hours left, maybe an hour to put their kid to bed. They should be able to go home safely. That's what should be able to happen. And so if you live in an environment that your leadership says, what did you do to cause this? That's the wrong question. The question is tell us what happened. That 92-year-old Asian lady is teaching us something, right? But it doesn't mean that the family member who comes in and is at the bedside gets to yell and kick you or touch you. And I think, I would encourage all leaders to not ask, what caused this? Or what did you do to cause this? Ask what happened. That's okay. But please don't blame the nurse or the PSW or even the patient. There are patients to be blamed. Like that second incident was the very first incident that caught my eye of the big issues. I didn't know there was such a grade that you could lightly touch my breasts. I didn't know there was a grading scale, right? It's not right. So there are issues we have to do. I don't know if I'm getting the questions right here. What are some of the ways that Ontario's regulatory colleges can help participate in this important work against violence against healthcare workers pose a threat to patient access to care? I will say my legal team is worried about this, about the colleges. My legal team has said that nurses will be afraid to report because patients could complain to the college about them, and then therefore they could, their license could be at risk. And so professional staff who do go through a college, and again, this has to go to the Ministry of Labor, this should go to the Ministry of Health to tackle this question, that a nurse, a PSW, a doctor should be able to feel comfortable in reporting and not be threatened by a college claim.
So just really quickly, just to that, and you brought it up earlier that your reporting has increased.
Yeah.
Best guess, how much is getting reported?
Probably 50% of it.
Yeah.
Yeah. It might be more, but it's increased, and that's a good thing. I'm very happy with the lost time because we're now paying attention, right? Just imagine like the OHA's work on all of that infrastructure, the policy, the training, the tools, the work that they did, put in the basics, and that they were in the quality improvement plan structure. That gave us the basics, but the basics are leading to a culture change. And I think that's an important concept as against 53. I'll ask if there's any other question. One more.
We have any in-house? No, and there's no more online?
It's a comment, but I don't think it's a question. I can put away, so I can't really see it. So I can watch.
So I think then with that, we are done for the day. So thank you, Mike.
Thank you very much.
So that'll be it for Longwoods for the summer. We always take July and August off, and we'll be back with you in September. We'll be making some changes to our events, and so we'll see how that goes over the next little bit. For those of you that are here, there's food. Take it, bring it home. All right, and that's it. Thank you very much. Have a wonderful day.
Thank you.